Thank you for tuning into this edition of The Science Behind, where in just a few minutes I will briefly describe the science behind the Total Thrombus Formation Analysis System 01, or TTAS. My name is Matt Sobo, a Scientific Product Manager at Diapharma, and I will be your host today. If you have any questions, please do not hesitate to reach out to us at info@diapharma.com, or you can visit our website at www.diapharma.com for additional information and resources for your use. When the vasculature is injured, by example, cutting yourself with a knife while washing the dishes, subendothelial collagen and tissue factor are exposed to the blood. The exposed collagen is very important for hemostasis and blood clot formation in primary hemostasis. There is a glycoprotein always present in the blood known as the Fondular factor that will bind to the exposed collagen and actually aggregate with itself. This self-aggregation is regulated by a protein called Adams13. Thrombotic complications can result when this self-aggregation is out of control, and it will be the subject of a different talk. The shape and conformation of these Fondular factor multimers and its ability to correctly bind to exposed collagen is dependent on the shear forces exerted on it by blood flowing past the endothelial wall. Now, platelets have multiple receptors on their cell membrane. One will recognize and bind to multimeric Fondular factor. The plate will then be shuttled down to the collagen, where a second receptor will bind the collagen directly, leading to platelet activation. Upon activation via collagen and the Fondular factor under shear stress, the platelet will change shape. It will become sticky by exposure to the GP2B3A receptor, and it will release granules containing, amongst others, the prothrombotic factors ADP, thromboxane A2, and serotonin. Now, serotonin is a vasoconstrictor, which means it will restrict the nearby blood flow to help minimize blood loss. ADP will bind nearby platelets at the P2Y12 receptor, which will attract additional platelets to the area, increasing aggregation. Thromboxane A2, or TXA2, will bind nearby platelets at the TP receptor. This will increase aggregation, but will also induce degranulation, releasing additional ADP and thromboxane into the blood. Another key method of platelet activation is at the PAR1 receptor. This receptor binds to thrombin that is activated concomitantly by the coagulation cascade. Seeing as activated platelets release factors that either attract or activate additional platelets to the area, it is easy to see that platelet activity progresses in a feed-forward mechanism. The GP2B3A activation allows the platelet to bind to the fibrin being generated in the coagulation component of hemostasis. The mesh of platelets and polymerized fibrin is what primarily constitutes the mature plug that will arrest bleeding or blood flow in the case of some venal or arterial emboli. Given their role in clotting of all sorts, including ischemic stroke, heart attacks, and venous thromboemboli, it isn't surprising that there are a number of different classes of platelet inhibitors, several of which are very common. Leading off with is aspirin. This drug irreversibly inhibits cyclooxygenase 1 from catalyzing the first reaction, which converts arachidonic acid to thromboxane A2, thereby preventing activation via this route. The next are the thiopyridine class of inhibitors. The class of drug blocks the P2Y12 receptor, preventing ADP binding, signaling, and aggregation. Examples are clopidogrel or Plavix, ticagrelor, and prasugrel. The last of the orally available platelet inhibitors is cilastazol, a phosphodiesterase inhibitor, which inhibits platelet aggregation. There are two classes of intravenously available platelet inhibition drugs, the GP2B3A inhibitors. Abciximab, abtifabetide, and tirafaban are all examples of this class of inhibitor. The class of drug prevents aggregation of platelets to one another and to fibrin. Also available are the direct thrombin inhibitors, such as argatroban, which will prevent platelet activation by removing thrombin from circulation so that it cannot bind to the PAR receptors present on platelets. The normal number of platelets present in the blood range from about 100,000 to about 400,000 platelets per microliter. Thrombocythemia and thrombocytosis are both instances of too many platelets, clinical designation at 500,000 per microliters. It is called thrombocythemia, or primary or essential thrombocythemia, when the mechanism is unknown. Overproduction of platelets in the bone marrow is the actual cause, but the why is unknown and is a small minority of cases. Thrombocytosis, also called reactive thrombocythemia, is the name that is used when the why is, in contrast, known. Typically, this is due to infection, chronic inflammation, or a tumorous malignancy as the driving force of the high platelet count. These forms account for the vast majority of cases. Thrombocytopenia, on the other hand, is the name used for having too few platelets. The condition is classified as severe if this number falls below 50,000 platelets per microliter. Thrombocytopenia can be genetic in nature, such as in Bernard-Soulier syndrome and some forms of von Willebrand disease. It can also be acquired. Examples include heparin-induced thrombocytopenia, Zika virus infection, or as a result of chemotherapy. A person with dysfunctional platelets may have a normal number of platelets, but they do not work correctly for various reasons. Glanzmann's thrombocythemia, the inability to form platelet to fibrin to platelet bonds. Many forms of von Willebrand disease is the ability to form platelet to collagen bonds. The TTAS 01 is a microchip flow chamber system to analyze thrombus formation under flow conditions. Micropump pushes whole blood through the capillary at a steady rate, while a sensitive pressure sensor measures the pressure exerted on the blood to achieve the desired flow rate through the microchip. Each chip contains 2 channels, each of which contains 26 collagen-coated microcapillaries in parallel. As the blood flows over the collagen coating, platelets will adhere and aggregate to the surface and one another, slowly occluding the channel. As this occlusion progresses, the pressure is required to maintain a constant flow rate increases and is measured and visualized graphically. As can be seen, the curve does not always ascend perfectly. These sudden drops in pressure occur when shear analytic forces overcome the platelet-fibrin bonds and send the piece of clot down the channel and begin forming a new clot in a dynamic process. The 26 parallel channels allow for a smoothing out of the effects and for internal normalization of the individual channels. Data are reported out as the area under the curve, or AUC. This number integrates the various drivers of primary hemostasis, the lag time to first formation, the rate of platelet aggregation, as well as the dissolution of said aggregates. A high AUC value corresponds to appropriate platelet clotting function. A low AUC value, conversely, corresponds to a weak, deficient, or inhibited clotting, or the flow of blood is not severely interrupted. The TTAS 01 with PL chip is FDA cleared for the analysis and evaluation of platelet thrombus formation, primary hemostatic function, in patients receiving antiplatelet therapy, such as aspirin, clopidogrel, prasugrel, or ticagrelor, and in patients with congenital platelet dysfunction, such as von Willebrand's disease or Glanzmann's thrombocythemia. Thank you for watching our brief introduction and to learn about the science behind the total thrombus formation analysis system. If you have any questions you would like to ask, please email us at info@diapharma.com and visit our website, www.diapharma.com.